but as of time, I'll restrict to only the limited things. Now we know that 80% of the patients of corona are going to be either mild or asymptomatic or into the minimal group, and majority of these have a fantastic recovery, but the remaining 20% of which can be divided into 15 and 5%, 5% for the critical care, and the remaining 15% for the severe. These are the ones who will require either the ICU or the HTU for the management. This is what we know. This is what we already know, and this is how the entire RCH is distributed into the management plans of having the number of isolation beds and the number of ICU beds. Now, it is important to understand that we identify the higher risk group amongst those who come to us, and amongst them are comorbidities, that is age above 50, those with IHTs, those with diabetes, hypertension. Majority of our patients coming to the RCH are or having a negative outcome are the ones who are having diabetes. And if you have an underlying disease like a chronic lung, liver, kidney, or any of these diseases, and with or without obesity, your prognosis is going to be a little graver than the rest. And then there are aspects of clinical management that need to be seen to decide the risk that you have for a negative outcome. Amongst them, the laboratory values are of importance, and this is how you scale the patients into a mild, a moderate, or a severe variety. This is what we are following at the COVID hospital. This is how the entire country is currently following this. It has been broken, if you look very closely, it has been broken up into the antiviral aspects of treatment, all mild, moderate, and severe. Then there will be an anticoagulation aspect. Then there will be supportive therapy. There are aspects of steroids. Then there is convalescent plasma therapy, and further on and further on. So as you move along the course of a mild, moderate, and severe, the intensity of management is going. But there are some things that are very, very common to all of them is the continuous monitoring that you need. There are certain indications. Now remember, there is a lot of literature which is still investigational. It is still going on. And we, as of now, are not sure as to how things will fan out in the coming few months, because this is being constantly updated. More research and more data is coming out, and what we believe now or today may not be relevant as more evidence comes out. Now, these are the, in the bracket, if you see, these are the number of investigational trials on different aspects of management in terms of general and supportive care that is currently going on. So all the bracket ones are these current studies which are going on all these aspects. So it can be dietary and supportive, it can be on ventilation, oxygenation, it can be on cardioprotective aspects, on CRRT, on cytosorb, on oxiris, on artificial liver systems, and on thromboprophylaxis. So these are how things are in terms of the general supportive care, in terms of research that may come in the coming times. Now, because I've been asked to look only into the treatment aspect related specifically to the antivirals, the immunomodulators, and the convalescent plasma. So this cartoon will bring everything together. So let us see. On the left side of the screen, you can see the spike proteins entering into the system, into the host. And so the activity of majority of drugs can start, say, for instance, how can I prevent the entry of this into the system? So there can be ACE2 receptor inhibitors, there can be ACE inhibitors, there can be angiotensin II receptor blockers. Then once it enters into the system, then there can be fusion inhibitors in terms of two, like immunoforin and, not wrong, it is bastinib. And then once it enters into, then there is going to be a component of endosomal acidification inhibitors are there. Like chloroquine and hydroxychloroquine. Once it moves further on, then there can be drugs which can act on the RNA polymerase inhibitors. Specific to these are the remdesivir and the ribavirin and favipiravir. These are important medications as we believe they are working today. Then we move further on into the aspects of main protease inhibitors like lopinavir, doranavir, and others in the cascade. There is also an important aspect of a passive immunization, which I and you understand, like the antibodies that are given from a person who's already sick and who has recovered, and plasma taken from that individual and then being instilled into somebody who's actually sick now, including convalescent plasma and intravenous immunoglobulins. And then there is a whole cascade of immunomodulators which will act on multiple aspects of this entire life cycle of the COVID or the coronavirus. It can include immunomodulators like tocilizumab. There is a whole list of drugs that you can see, and some of the ones that need reference are the corticosteroids, chloroquine, hydroxychloroquine, then leflunomide, then thalidomide, azithromycin, colchicine, cell therapy. And in the bracket, again, as I said, these are the number of investigational trials which are currently going on. So literature is fastly expanding. This is just a 6-month-old virus, okay? So what we know today may not be relevant tomorrow. If you look into the most important ones that we are now using for the treatment, the topmost of the ladder will be chloroquine and hydroxychloroquine. Both of them antimalarials, have got in vitro activity, immunomodulators. They will inhibit viral enzymes and H2 cellular receptor inhibition, and they have certain adverse consequences like QT prolongation, retinal damage, caution in G6PD deficiency, caution in diabetics, and drug interactions. As we move down the cascade, there are drugs like lopinavir, then there is remdesivir, which I'll elaborate as I go on. I'm just starting it here. So remdesivir is the most important one that I and you are currently using, and it is a nucleotide prodrug of an adenosine analog. Recommendations state these are recommendations from the National Institute of Health, and these have been published on July 31st, last day of July. So these are the most current and updated. Now the recommendations are that because the supply is so limited, therefore use it only for patients on very restrictive use, for patients on supplemental oxygen. But remember the third line which I'm writing, but it is not okay if you want to use it for high flow oxygen devices, for NIV patients, for mechanical ventilation, for ECMO. Therefore, the entire treatment spectrum is moving on to the early. Bring it on early, bring it on in the milder stage. Don't wait for the illness to go on to the moderate. And once it goes on to the severe or the cytokine storm stage, nothing is going to work. So bring every modality of treatment onto the milder. So this is a paradigm shift from what we have been reading in the initial stage, that bring on these investigational therapies more into the moderate and the severe ones. But now it is shifting on to the milder forms. Therefore, now it is recommended if the patient is already on high flow oxygen devices, NIV, mechanical ventilation, ECMO, for instance, these will not work. It's already far gone beyond repair. And most of the data for remdesivir comes from mild or moderate COVID-19. There is insufficient data as per the NIH to either favor it or recommend against it. Supplemental oxygen, remdesivir duration is only for 5 days. There are comparative trials for 5 days versus 10 days. The duration of therapy as of now for patients who are not responding for 5-day therapy is not enough evidence. So people are believing only some experts. The level of evidence is already written is that you can extend the therapy to 10 days, but this is just only an expert opinion, not really evidence-based. Now the rationale for this remdesivir starts from the adaptive COVID-19. This is the largest one that is available. NIH-sponsored multinational trial of 1,063 patients. The interpretation, it was a placebo versus a remdesivir 10-day trial, and the interpretation is that it reduced the time to clinical recovery, maximum benefit only for patients who required supplemental oxygen. No observed benefit, as I did mention in the previous slide, to those who are on NIV, mechanical ventilation, or ECMO. The second one is the multi-center double-blinded RCT that was evaluated from patients in severe COVID-19 in China. Again, randomization here was 2:1. Remdesivir versus placebo for 10 days. Concomitantly, patients were used on lopinavir and ritonavir, and steroids and interferons were also allowed in this patient. Interpretation, no difference in time to clinical improvement, 28-day mortality or the rate of viral clearance. The third one is the multinational RCT. It is a manufacturer-sponsored trial. Interpretation, 5-day versus 10-day. 5-day is more than enough for these patients. 10-day may not be required. So contraindications, as you remember, are those that AST and ALT, most of the times what we see is more than 5 times, so we will not give them. Or if the patient is having a severe renal impairment, don't give them. No dose adjustment is required for EGFR above 30. Now, the most people want to hear about the chloroquine and the hydroxychloroquine. The recommendations from the NIH are against the use, except if you are doing a clinical trial. So even for treatment or for prophylaxis, the recommendations are going against chloroquine and hydroxychloroquine. These are small RCTs, most data from mild cases. There is no evidence of benefit. FDA cautions against the use and monitor the adverse effects. And again, it is not associated with any harm or benefit as per the from the New York study. Then there's no beneficial effect. If you add azithromycin to this, there's no difference in viral clearance. Favipiravir is one more, which is used for milder cases. It's a broad spectrum antiviral. Indications are only for milder forms, contraindicated in pregnancy and lactation. This is the new kid in the block, but not recommended as per the NIH. Is the ivermectin being used? Broad spectrum antiviral. It is more of in vivo data, more of in vitro data, not of in vivo. So human trials are going on. This is a broad spectrum, so it will be anti-helminthic plus it will be against RNA virus as well as the DNA virus. There's a whole lot of things that can be said about ivermectin, but for the moment, I can just give this much. Immunomodulators, the recommendations are that on the basis of preliminary report, based on the recovery trial, the panel recommends dexamethasone 6 milligrams IVOD for 10 days. And for the treatment of COVID-19 patients who are mechanically ventilated, and the panel does recommend against using dexamethasone in patients who do not require oxygen. So do not give dexamethasone if you are not requiring oxygen. And other immunomodulators like interleukin-1 inhibitors, IL-6 and interferon, these are recommendations neither for or against. For the interferons, and again, recommendations are against the use of these immunomodulators. I'll skip this slide. Then for blood-derived product, there is insufficient data either in favor or against this. And the panel does, the NIH panel does recommend against use of mesenchymal stem cells or for immunoglobulins in these patients. So the recommendations are against these. I'll just wind it up. Thank you for the time. I know it is a very short time. Thank you for the opportunity.
So vaccine development traditionally is a very long and arduous process. It usually takes about 1 to 2 decades. It starts with identification of immunodominant antigen and an appropriate adjuvant, which will give you a very good immunological response and will also be protective. So initially, preclinical trials are done in small animals like mouse, rat, and when you see immunogenicity and safety, you move on to animal models which are relevant animal models. Like for SARS-CoV-2, it is ferret or mouse which is expressing ACE2 transgenically. And after that, you have to show efficacy and prevention of infection in a non-human primate model like monkey or chimpanzee. So all this takes about 5 to 10 years. Once you have the data in the animals, the regulators will give approval for first-in-human trials. The human trials can be divided into 4 phases. The phase 1 is actually to test safety of the vaccine. It's given to a small number of individuals, usually between 40 to 100, initially healthy controls who are young adults, and then in different age groups. Once you find that the vaccine is safe, then starts the efficacy. Initially, the trials are done, that is called the phase 2 trials, where you enroll about 100 to 300 individuals. You look at, do you get immunogenicity in humans? Because always the data which you generate in animals is not equivalently seen in humans. And then once you have good data of safety and immunogenicity, large trials are started, which will have thousands of individuals going up to million, depending on the prevalence of that infection. You have to show that the vaccine is safe, effective, either it reduces the infection severity or it prevents infection. All this takes about 10 to 15 years. But during the pandemic, we don't have time. We have to compress everything in a short period of this. And as you've seen, in the last 6 months, we already have vaccines which have come onto the phase 3 trial. How has this happened? This has happened because initially we were doing things in series. Every step used to follow another step, and we would wait for the data to come from phase 1 trial before moving on to phase 2 trials. But now all the things are being done in parallel. And when you do things in parallel, what happens? You are taking extra risk that the things may fail. And this is happening because the international community and the vaccine centers like Gavi, CEPI, Bill and Melinda Gates Foundation, and different countries have pledged billions of dollars to allow us to take risk. And that is why we are having so many vaccines being developed. And what are the different vaccine strategies we have? Obviously, the best is to have the virus, which will have most of the antigens. So it could be an inactivated or a weakened virus. It could be that you're taking a viral vector like measles, rabies, and you're putting the genes of this virus into it. Or it could be the nucleic material of the virus. And obviously, if you know the immunodominant antigen, you use that. And this is the bar diagram is showing you the vaccines which are against SARS-CoV-2, which are in different phases of development. So the maximum number of candidate vaccines are actually using protein-based strategy. So as I said, the whole virus is the best. But to get a weakened virus, you need to passage the virus multiple times in animals or human cells so that it does not revert back to the pathogenic virus. The second is that you can inactivate the virus by using chemicals, or you can use nucleic acids. These are more easy to make. So as you're seeing that most of the vaccines which are going into trials at this stage are RNA vaccines, because you can synthesize RNA in the lab. But the problem with RNA viruses is the stability. How long does the RNA survive in the cell? For the DNA, it's very, very easy to make, but the problem is the delivery. And whenever we give any extra DNA from outside, it can get integrated into our host DNA and can cause mutagenesis. Then you have the viral vectors, where you're using some other virals to carry the genes of coronavirus. And this strategy is also very good, and a lot of vaccines which are in trial are also using this. And finally, you can use a cocktail of the antigens, the spike antigens we every day hear. That is the most immunogenic, but you can also add other antigens of the virus and give a cocktail to have a more robust immune response. So if you compare the various vaccine strategies, the nucleic acid based vaccines are the most easy to make. They can be made very fast. And the Moderna vaccine, which is also spearheaded by NIH, is actually an mRNA based vaccine. The Zydus vaccine, which has come into the market, is a DNA vaccine. So we have different strategies working in different vaccines. What do you want from the vaccine? We want a very good neutralizing antibody development. So I'm just giving you the data from one of the vaccines. This is the Moderna NIH vaccine, and this is the data from the non-human primate experiments, where macaques were given the vaccine in 2 different dosage. And obviously, if you give the higher dose, you get much higher neutralizing antibody. You also develop a responsive CD4 T cell response. This is what we wanted, because once you get a good T cell response, it is likely that the antibodies will persist for a longer period of time. The second, we want that the antibodies should be neutralizing antibodies. So this is showing you that the antibodies which develop following the virus are highly neutralizing. They prevent binding of the ACE2, and it is better than the convalescent sera. Similarly, it is also neutralizing the virus in another experiment, which is better than the convalescent sera. And obviously, the proof comes when you give challenge with the virus. So on giving challenge with the virus, as you see, because the monkeys don't develop the disease, they only get infection. So the infection is almost absent, nearly absent in the animals which were given the vaccine. While in the PBS treated mice, as PBS treated monkeys, you got infection on day 2, but because the monkey doesn't develop the disease, it clears it by the day 7. So at present, there are 165 vaccines which are under development. And of those, 37 are in clinical trials in humans. And one of them has got approval, but it is a restricted approval. It's a Chinese vaccine, which is being approved, which has been approved to be used by the military personnel in the Chinese army. We'll just see the 6 vaccines which are in the phase 3 trial. And these are the vaccines which are in the phase 3 trial. We have heard so much about the Oxford vaccine. The Oxford vaccine is actually an adenovirus-based vaccine, which is using the adenovirus vector, and it has gone into the phase 3 trial on July 15th in Brazil and in UK, and they are planning to enroll about 15,000 subjects in this. The Moderna vaccine and the Pfizer vaccine, which is an mRNA-based vaccine, is each planning to enroll 30,000 subjects. The 2 vaccines which are being made in China, which are both based on inactivated virus, are also enrolling subjects of around 10,000 to 15,000. The Sinovac vaccine is being tried in a high-risk group. So they are doing this trial in healthcare workers. Because if you have a higher exposure, you can reduce your number of subjects which you need to enroll. The Inovio vaccine is a DNA vaccine which is going to move into the phase 3 trial very soon, or it may have moved today. What is the Indian story? We already have 2 vaccines which have in the human trial. One is the Covaxin, which is an inactivated virus vaccine, and it has, on August 6th, it has again moved into the phase 2 trial. While the vaccine from the Zydus Cadila is a DNA-based vaccine, and it has also moved, both of them have been proven to be safe in the phase 1 trial, and they are both in the phase 2 trial. And this month, the DCGI has given approval to Serum Institute of India to start the Oxford vaccine trial. And we also have other companies which are trying with different ideas, and among them, the Bharat Biotech is using the rabies-based vector vaccine, and it is showing good data in the preclinical studies. Yeah. So what are we fearing? When we give vaccine, nothing comes without a baggage. The vaccine also, we are fearful that it may cause antibody-dependent enhancement of the disease. Because what we want is neutralizing antibody, which will neutralize the virus. But if you, in addition, develop non-neutralizing antibodies, they can make the virus more tasty for the macrophage to take in, and that will cause more infection of the macrophages. Similarly, if you develop non-neutralizing antibody, it can activate the macrophages to produce pro-inflammatory cytokines, and that can cause increase in the lung damage. So at present, there's a lot between the cup and the lip. We really don't know what is the best antigen. Is it the full spike protein, or should we be concentrating on receptor binding domain? Should we be using combination of antigens? If combination, what ratios of different antigen? Is the DNA vaccine better? Is the RNA vaccine better? Is the vector vaccine better? How long will the protection last? Do we need boosters? And what are the real immune correlates of protection? We think that T cell response is a better response than the antibody response, but we still don't know. And we are still worried about vaccine-associated enhanced respiratory disease, which was seen in other vaccines, which are mediated by Th2-mediated response and non-neutralizing antibody. I'll just take 1 minute on BCG vaccine, because a lot of people don't believe in it, but still there are lots of trials which are enrolled for BCG vaccine. BCG vaccine, in contrast, only enhances our innate immunity. It makes our innate cells more capable of killing the virus. So till we get a good vaccine, people are thinking that can we give vaccines which we already have to just improve our innate immunity. So what I would say, that we still have a long way to go, but we have done very well. And I think as a community, we need to be proud of that. Till we get the vaccine, please follow these preventive measures and we'll all be safe. Thank you.
I think we can only talk about very basic aspects of risks and safety. We talk about magnitude of risk worldwide, and we realize that the percentage of healthcare workers reported positive in from various institutions across the world vary from about 1% to about 6 or 7%. The figure also varies because of the kind of population tested, asymptomatic screening versus only symptomatic testing. But the general figure has been below 5% or around that point. The data from Indian subcontinent or India particularly, this is the first is a series from a private hospital in Delhi, which gave us a COVID positive incidence rate of 1.8%, but only in symptomatic people. The second one is the one which is quoted all over the world, had occupied all over the country, or had occupied all of newspaper headlines, gave us a figure of 28% asymptomatic in the Indian population. And so it showed us that the risks in our particular population for healthcare workers is almost in line with what the world population shows. When we talk about safety and how to prevent it in terms of risks, we need to understand the modes of spread. I'm not going to go into details because I think in last CGR it was covered already, but suffice to say that the predominant mode of spread is droplet and aerosol. However, there are other modes of spread. We don't know how important they are, but they have to be taken into consideration when we talk about protection of healthcare workers, which means airborne, direct contact, fomites, indirect contact. And hence, we have to incorporate all these protection measures when we talk about the safety. just listed 4 points in which I think broadly they could be divided as to how do we ensure safety: personal protective equipment, the PPE, behavioral change, chemoprophylaxis, and administrative safety net. This is Peter Sai, who was the inventor of the N95 respirator. The N95 respirator is now the backbone of the PPE that we recommend all over the institution and across the world. Broadly speaking, PPE consists of these components, give or take 1 or 2 here and there, depending on the kit you're using: the mask, the protection in the eye, the gowns or aprons or coveralls, gloves, and the foot covers, which can be either only the feet, to ankle, or to the knee. This is what we are used to seeing: the coverall or the gown-based PPE, which we are using in RCH as well. Now, when we talk about PPE, just technology and availability of PPE is not enough. And we have our own teams from RCH have, I can emphasize this, that we have to have particular donning and doffing techniques, without which even having adequate equipment is useless. And CDC recommended guidelines are these. It's important to follow some guidelines. Our own institution has done a lot of work in trying to train our own users. The bottom line is that self-training is not a good idea as far as donning and doffing techniques go. The other question we often ask is that, do we need to wear the entire set of PPE, and how much do I need to wear depending on where I am in the hospital or in the institution? So in the green is the complete PPE, and the orange or the yellow part is the PPE which we usually see in the rest of the hospital. With regard to where to use what, and this is a question asked by various healthcare workers, not only doctors, nurses, sanitation workers. The Ministry of Health has given us guidelines, and we can broadly follow those. This is a long 10-page PDF document available on the internet. So I cannot go into details of this right now, but it has given us some leeway about what we can do with our own resources. But it gives you very clearly as to who should be doing what in terms of wearing PPE: the ambulance drivers, the sanitation workers, the nursing staff working outside, the receptionist, and so on and so forth. Question often asked is that, are all components of PPE equally effective? Well, the dominant mode of spread is aerosol and droplet. So are the rest of them as equally effective as just a good N95 mask? Well, this is data from a Lancet meta-analysis, which tells us that the eye protection gave us independent association with reduced infection rate. So yes, all components of PPE seem to be having an effect as far as protection of the healthcare worker goes. Equally important is the fact that while we may scoff at formal donning and doffing techniques, formal user training, meta-analysis has shown us that this is very important, and as opposed to self-learning or of modification of donning and doffing techniques, they offer much better protection for the healthcare worker. We need a behavioral change. There should be a culture of safety, and every person at the workplace should be treated as a potentially COVID positive. This includes patients as well as co-workers. I'm going to show a very busy slide. Bear with me. This is a slide which is from Lancet, published a couple of weeks back, which told us how the infection spreads through the community, various stages of community spread, and how that impacts the likely source of healthcare worker infection. These are various stages of community spread, and these are the sources of infection to the healthcare worker. Where are we? My guess is we are here somewhere. Why do I say that? Because it seems that majority of, and this is from data of our own institution, majority of the infections of healthcare workers in our institution have been from community or our own healthcare workers, co-workers. And that is why I harp on the behavioral change, which we keep on talking about in social media. I hope we don't get here. And when we do, if we do, then is when patients become a major source of infection to us. Chemoprophylaxis, I think Dr. Singh has spoken about this. There's a lot of controversy. I'm not going to go into all that. He's touched upon it a little bit. Just to tell you that as of today, this may change in future, ICMR and Government of India continue to recommend hydroxychloroquine for chemoprophylaxis of healthcare workers. And this is the study, ICMR study, which is often quoted, on which this recommendation is based. Protection starts after the 3rd week. So don't expect that if you have a duty tomorrow, starting the hydroxychloroquine today will help. It's often said that as the infection goes through the community, healthcare worker, if infection is bound to occur. I think it's a myth, and this is a chart from a very busy chart from the Wuhan hospital, near tertiary hospital in Wuhan itself. The yellow line is what shows us as the infection increased in Wuhan. It was bound for the naysayers to see that the healthcare worker infections should have also gone up. The bars are the healthcare worker infections. Forget the colors and the codings. The bars are the healthcare worker infections, and you can see that as the infection rate in Wuhan increased, the healthcare worker infection actually reduced. It just tells you that putting measures into place and following them actually can protect you and prevent this crisis from emerging. Peter Tsai came out of retirement this year and is now a part of this scientific consortium. I put this there because this is a website of the N95 Decon group, which is actually the driver group of all the publications which ultimately the CDC uses to recommend the reuse of N95 masks. What do we have today? As of today, the acceptable methods of reuse are what we are following today, the cheapest and the simplest, wait and reuse. The recommendation is that one N95 can be used for 5 times at least, and therefore we use that 5 mask, 5-day principle that we recommended from our own hospital. Others are hydrogen peroxide vapors, which is sterile that we have in our own hospitals, so far not used for decontamination, UVC, and moist heat as well. What are not to be used, and this is important. This seems common sense that we can easily use a microwave or ETO2 or even our own liquid hydrogen peroxide as available in our wards to reuse. It is not an acceptable method as far as data today goes. Now, a very important modality of risk to the healthcare workers is physical assault. We don't talk about it very often. WHO has a website, and that is surveillance system for attacks on healthcare workers. It shows us up to 7th of August, that is yesterday, number of attacks taken place was 193 and number of injuries to healthcare workers 155. Of course, these attacks are cluster attacks. You can't talk about it from individual perspective. When you change that country field to India, let's see what it shows. This is the shameful part. We know this is not true because all of us have read headlines like this and much more. This is just a couple of them. A lot of them go unreported. The very important aspect of healthcare worker risk is also physical assault. The shameful part really when we aim to become a world superpower is that this is a chart from the same website which tells you which countries have reported their own healthcare worker attacks. Syria, Sudan, Afghanistan, and we say these are third world countries and we are the budding superpower. I think we have to do a lot of stuff before we actually get there. Thank you.
I've been asked to discuss few issues relating what impact this COVID-19 pandemic has had on the practice and outcomes of surgery and non-surgical interventions. Well, there's no denying the fact that this pandemic is a clear and present danger to the entire world, and it has impacted all aspects of clinical practice, not just in India, not just in a few countries, but globally. And this impact is felt more on surgical and non-surgical interventional practices, because these are interventions or procedures which are perceived to be of greater degree of danger to the healthcare workers and for transmission of infection. The pandemic has indeed brought a change to the perceptions, how surgeons and other interventionists see our practices. It has forced a change in the protocols that we are practicing or are following today, and it has resulted in some definite change in our practices and seems to have changed or altered the performance or the outcomes of surgeons and other interventionists. What is guiding the practice and policies for surgeons and other people who are practicing interventions? Well, we all believe, or at least we tend to believe, that we practice based on solid scientific evidence. We practice evidence-based medicine. But in this era where everything has happened in such a short span of time, there are so many uncertainties. Unfortunately, we are forced to practice based on our intuition and our beliefs more than based on solid scientific data. The available evidence, though meager, it all relates to some prospective and many retrospective cohort studies. And in recent couple of months, there have been a few rather small systematic reviews and meta-analysis. But by and large, how we practice is based on the expert views, and which also reflect in the guidances provided by many international and national scientific societies or professional societies. So in absence of solid prospective scientific evidence, it makes sense to be logical, and the logic says that in such times of uncertainties, we follow this kind of an approach where we plan, we do certain things, and then we check again and act or adjust according to what we found in our initial practice or the results of the initial practice. It seems very logical that we be selective and judicious in offering surgery or interventions to patients who are at greatest need for them and who are at an urgent need for them. As much as possible, we can avoid or postpone or delay the surgery or interventions until it is a safer time. More and more, we are using non-operative or non-intervention alternatives where they exist, unless, of course, the surgery or intervention itself is perceived to be life-saving. There are a number of examples where alternative strategies have worked well, and I'm just using one of those examples. Early stage breast cancers, which are hormone receptor positive, or in other words, hormone responsive, they had been conventionally treated with primary surgery first, followed by adjuvant treatment. However, in this time of pandemic, globally, we have changed our practice. Patients are put on neoadjuvant or pre-operative hormone treatment, and it makes good sense because it gives you time to postpone the surgery until the pandemic is over, or it is at least somewhat contained. And a question that is often asked, whether this postponement of surgery, would it have an impact on the survival of these patients? And then a paper which is about to come or is on the website of Journal of American College of Surgeons now, it very clearly shows that by delaying surgery by up to 120 days, we are not impairing the survival chances of these early stage breast cancers. So in the current era, we need to find a fine balance between the risk of adverse events or adverse outcomes related to delay in treatment or delay of surgery and interventions, and so compromise disease control, versus the risk of death or serious morbidity on account of COVID, both for the patient and to the health systems or healthcare workers. Of course, it also makes sense to mention that one must operate or intervene where one has to, where the disease is such that if we delay it further, it may cause serious harm to the patient's life. And wherever such a intervention or operation is planned, it has to be done with full preparedness to minimize the risk of COVID infection, both to the patient and for the healthcare workers or their adverse outcomes. So a central point to this whole scheme of practice today is assigning risk to individual patients. The patients may be confirmed cases of COVID infection on one hand of the spectrum, or they may be tested and found negative on the other hand of the spectrum, but there would be quite a few patients who are either probable cases or suspected cases where either the disease has not given you a sufficient time to test for COVID infection, or the test has been done, but it has either been equivocal, or even though the test report results may be negative, but the clinical index of suspicion is so high that you would like to consider the false negative part of, or false negative results of COVID testing. Something which Dr. Rajneesh has touched upon, wherever you're planning surgery or interventions, these are considered aerosol generating procedures at highest possible risk of transmission of infection. So these people who are indulging or who are participating in the surgery or interventions need to have the highest level of protection in terms of personal protective equipment and masks or respirators, and I will not elaborate it further. So here on, I would discuss certain specific issues relating surgical practice and how it has been impacted by COVID-19 pandemic and the outcomes of surgery, and also touch upon briefly on how cardiac interventions and GI endoscopy or interventions have been impacted by the COVID pandemic. And I would like to acknowledge my friends, Dr. Aditya Kapoor and Dr. Sameer Mahindra, for helping me with this part of the presentation. Well, as far as surgery is concerned, there are a number of societies, global, international, national, which have brought about guidances and guidelines about relating how surgical care has to be imparted during the pandemic. While they may vary to some extent, but there are a number of commonalities, and all of them have brought out specific guidances regarding how we need to triage patients, what kind of pre-admission and pre-operative or pre-intervention considerations are required, and then of course the peri-operative and post-operative considerations. One must categorize patients into non-infected, potentially infected, and definitely infected groups because the three groups require somewhat different approach. All patients must be tested for COVID today because there is a certain risk, indefinite risk involved in operating or intervening in patients who are COVID positive, unless the disease, the condition that you're treating is life-threatening and it precludes RT-PCR testing or COVID testing. One must have a dedicated operating system, operating room, pre and post-operative anesthetic and then care areas for patients who are COVID infected, and these patients must be isolated from non-COVID patients, and the counseling and consenting in these patients who are COVID positive or probably positive, that has to be specific. Even for patients who are COVID negative, they must be informed and have to be consented for somewhat higher risk than usual in terms of pulmonary complications and other adverse outcomes. In terms of how we manage the patients peri-operatively, before we operate, one must prepare and train the healthcare workers and the entire health system for various specific tasks that they have to undertake, including for appropriate usage of PPEs or the personal protective equipment and respirator masks. One must minimize the number of staff in the operating rooms. Operating rooms themselves have to be prepared appropriately. Ideally, there should be negative pressure rooms with minimal essential equipment inside. During surgery, one must try and minimize or contain the aerosol generation, either, for example, by using video laryngoscope and containment boxes and using appropriate filters in the anesthetic circuits. Appropriate PPEs and mask respirators are essential for all participants in the surgery. Use of smoke evacuators and judicious or minimal use of certain techniques and technologies which may put a patient at a high risk of COVID infection should be minimized. Post-operatively, patients who are infected or potentially infected must be isolated. They must be monitored for COVID infection or unknown, even if they are negative or unknown for COVID. And specific protocols for decontamination and sanitizations must be practiced universally. Okay. In terms of outcomes of surgery in patients who have COVID infection, the first question that comes to mind is whether patients who have COVID infection, they are at a higher risk of death or serious morbidity. So there is some data available. This study from Italy, it reported a matched cohort of 41 patients with COVID infection with a control group of 82 patients who were COVID negative, and the 30-day mortality and serious complications were significantly higher in patients who were COVID positive or infected compared to those who were COVID negative. Another question comes to mind is whether it is important to test all patients for COVID infection before operating. This review done by investigators from Israel, published in World Journal of Surgery, used 6 studies which pooled 64 patients, and the mortality rates of such patients who were operated during the presumed incubation period for COVID was definitely much higher at 27.5%, which is unacceptably high. And these patients had severe pulmonary complications, and it also resulted in serious exposure of the staff and infection transmission. So it does recommend screening for COVID infection for all patients who may be asymptomatic for COVID prior to surgery. COVID Surge Collaborative is a major collaborative effort led by investigators from University of Birmingham. And in this international multi-center cohort study published by the COVID Surge Collaborative, which included data from 235 hospitals in 24 countries, they looked at what was the risk of death within 30 days following surgery in patients who had COVID infection. Also looked at the risk of pulmonary complications defined as pneumonia and ARDS. And in this study, a total of 1,128 patients were included, and about 24% of them died, which is definitely much higher than perioperative mortality in any era. Of these patients, roughly about 3/4 of them underwent emergency surgery, and these patients who had emergency surgery had much higher mortality rates as compared to those who had elective surgery. The predictors for 30-day mortality were age more than 70 years, male gender, ASA grade 3 and 3 to 5, multiple comorbidities, surgery for cancer, emergency surgery, and major surgery vis-a-vis minor surgery. So in these patients, pulmonary complications were the major cause for mortality. In all, 24% of patients died. Mortality rates were higher in patients who had pulmonary complications. This mortality rate was 40%, and serious pneumonia and ARDS were the causes. While we are now unlocking it, the question that whether elective surgery should be started and is it safe, this question is answered in some small studies, including this one, which reported 621 consecutive cancer patients who underwent elective surgery. None of them died, and this is pretty much the kind of experience we have had here as well. Very briefly, how has COVID impacted the cardiac interventions? It has indeed impacted and raised a number of questions, which have led to even questions being asked in popular media and in newspapers. Where have all the heart attacks gone? It seems that the number of serious heart attacks or cardiac illnesses have gone down significantly. There's a definite reduction in intervention procedures, and there's a shift towards acute procedures only and deferment of elective procedures. Intervention in cases of acute coronary syndrome is being done only after very serious risk stratification. And where it seems that when properly risk stratified and managed accordingly, patients who have COVID-19 infection, they have similar outcomes as compared to patients who were treated prior to the pandemic. And in interest of time, I would skip much of these details, but there is data from US, from Spain, and other networks which suggests that the number of patients being intervened or undergoing PCIs is much lesser today. There are guidances from American Society, from the European Society of Cardiology, which provide specific guidances regarding how to manage ST-elevated MIs and non-ST-elevated MIs. And there is data to suggest that in patients who are carefully selected and risk stratified, the outcomes are similar to the earlier era. And in the end, how has COVID-19 pandemic impacted the practice and outcomes or interventions of GI endoscopy? There are a number of polls or surveys which have been done internationally and in various countries, including India, and more or less all of them, they suggest that there's a substantial reduction in number of GI endoscopy procedures being performed all across the globe. These cancellations or reduction in emergency as well as elective endoscopy procedures, they may be impacting the outcomes for approximately 1/4 of all patients. All these surveys, they underscore the importance of appropriate PPEs for the whole endoscopy team, importance of room sterilization and pre-procedure screening for all patients. There is a certain big risk of infection transmission to patients as well as healthcare workers, which has been brought about by these surveys. There seems to be a rather low risk of transmission, as has been brought about by 2 case series from northern Italy, and that these data suggest that GI endoscopy is relatively safe both for the patient and healthcare workers when adequate protective measures are used. So to summarize, the COVID-19 pandemic has impacted the practice and outcomes of surgery and non-surgical interventions. The interventions must be, they can result in serious adverse events for the patients as well as for the healthcare workers. Interventions must be selective. One needs to find the balance between managing the disease burden and adequately managing the outcomes, and on the other hand, reducing the risk to the patients and the healthcare workers. If only essential, patients must be operated or intervened with full preparedness. The 30-day mortality rates are higher in patients who are COVID-19 infected. because of serious pulmonary morbidity and complications. And the predictors are, as I discussed earlier, all patients must be screened for COVID-19 infection before undergoing elective surgery or wherever possible, because there is a higher mortality and pulmonary morbidity in patients who manifest with COVID-19 post-operatively, or in other words, these are patients who may be operated during the incubation period of COVID-19. Thank you.